Hello, this is Dr. Paul Whelton from Tulane University in New Orleans, and I have a wonderful pleasure today of speaking with Professor Dr. Jing Li from Peking Union Medical College and the Chinese Academy of Medical Sciences in Beijing. And she's done a very, very interesting trial. So, Dr. Li, nice to be with you. Maybe you tell us a little bit about the new trial you're presenting here at the American Heart Association meetings.
Yeah, that's a large trial which randomized about 11,000 participants with hypertension and high cardiovascular risk. So we want to assess the effects of intensive blood pressure lowering treatment, which means targeting systolic blood pressure below 120 millimeter mercury compared with targeting systolic blood pressure below 140. So we want to assess the effects on the major vascular events. That means heart attack, stroke, revascularization, hospital for heart failure, and cardiovascular death.
And now the big reveal, what did you find?
Yeah, so the result is a little out of our expectation. We found that actually the intensive treatment is better than standard treatment, reduce the vascular events, and the result is out of our expectation because we found that actually the safety profile is very good.
Mm-hmm.
Yeah, and the adverse events, serious adverse events of interest is rare.
So your primary outcome, as I understand, was a composite of cardiovascular events. Maybe you tell us a little bit about what was in that primary outcome.
Yeah, and we found that actually the intensive blood pressure, intensive treatment group has 12% lower risk than the standard treatment group.
And what about the particular components of the cardiovascular composite? Were they all showing improvement, or was there anything that seemed to go in the wrong direction?
Yeah, actually the benefit, I think that is mainly driven by the reduction in cardiovascular mortality. The risk of cardiovascular death reduced 39%, and also the hospital for heart failure reduced, and myocardial infarction and stroke, but there seems no effects in revascularization.
Right. So your average age, as I recall, was about 64, 66 for your participants at baseline? Years? 66 years, was it, at baseline? The average age?
65, yeah.
65, yeah. So that's similar, maybe a slightly different, but similar to some of the other trials that have looked at this. Now, the other trials have been done in the West, and what we've really seen in those trials is an effect across the board, but a big effect on heart failure. And did you have many heart failure outcomes, and did you see benefit for heart failure?
Yes, we see that clear benefit for heart failure, but the event number of heart failure is not much.
Yes, it was interesting to me.
Because we excluded patients with reduced left ventricular ejection fraction at baseline.
So we seem to have a pattern here now from your trial, which is a wonderful trial, and congratulations, very well done. I should say you lost only 5 participants to follow up, as I recall it, in the 2 hours, which is really impressive. It's very, very nicely done. So there's a pattern here, SPRINT, Accord BP, when it's analyzed, standard glycemic care group seem to have the same effect as SPRINT, and then RESPECT and your trial. So what do you think? Do you think the Do you think the message is conclusive now? Should guideline committees be considering a lower target?
Yes, I think it's conclusive.
Yeah.
Yeah, all the trials together, I think that's consistent. They are consistent, and just like a big jack puzzle, and one piece,
Right.
another piece, and
Right.
all together, we can see the whole message is clear. Yeah.
And of course, obviously, when we're doing more intensive reduction in blood pressure, we worry about adverse effects. And you said already you didn't see any difference between the two groups in serious adverse effects. How about specific ones? How about the kidney? Did you see changes in the kidney? Most of these trials have seen what may be hemodynamic effects, but we worry about it.
Yeah, actually, there are two outcomes of kidney. One is the safety outcome in our study, the acute kidney injury or acute renal failure. We don't see any difference between the two arms. And the incidence is very low. And another kidney outcomes is a secondary outcome of kidney is the composite kidney outcomes. That means that the renal dies, the end-stage renal failure, and decrease at higher than 40% of EGFR. For that result, we did see a higher risk in the intensive treatment group as sprint. But I think that the benefit of save lives is much important and much bigger than the.
Yeah. Of course, we also worry about other organs. Usually we think about the brain, did people get hypotension? Did they get syncope? On the positive side, we wonder, did their cognitive function improve, or at least not get worse? And what happened to dementia? Have you any information that you can share on some of those outcomes?
Yes, we did measure the cognitive function at the baseline and at the final follow-up, but we haven't finished the analysis. But according to the results of a stroke event, we just saw less stroke in intensive group. So it's possible that maybe intensive treatment is better for cognitive, but we should wait for the results.
I think, of course, the cardiovascular events we know occur earlier than we would expect the major kidney or brain events to occur. So maybe pooling of these trials will be helpful to look at sort of rare outcomes like dementia. And the heart, you saw no evidence that there was any uptick in cardiovascular events from hyperperfusion of the heart. The myocardial infarction was going in the right direction.
Yeah.
What do you think is the next step? What needs to be done at your end, and how would you like to see your results being implemented?
I think that if with further longer follow-up, we can see better results, the more benefit, because after the 2 years, we saw the two groups separate, and the difference grew rapidly. And so we will do further follow-up, post-trial follow-up. Although post-trial, we don't provide free drugs, but we encourage them to continue their antihypertensive treatment. So maybe helpful.
There are, as you well know, there are some other trials. I know of 3. I'm involved with 2 in Brazil, the optimal trial in diabetics and the optimal trial in stroke survivors. And in China, there is the BP Road. So we will get additional information, and I think the whole picture is going to become much clearer over the next year or 2. So congratulations. It's a really nicely done trial and a very important trial and good results. I'm going to give you a high five.